Thank you for watching our video on cortical stimulation with SEEG. What I'd like to start with is just a broad overview on what SEEG is all about. Just kind of as a reminder. So when a patient is admitted for SEEG monitoring, this involves that the first day of the admission, the patient will have about 10 to 16 SEEG electrodes placed deep in the brain. So you can see all these electrodes are placed deep into the brain. And those electrodes go in the area where we think the seizures are coming from. And those electrodes allow us to very precisely define where the patient's seizures are coming from. So during the week or so that the patient's undergoing SEEG monitoring, we're taking them off their seizure meds, we're recording seizures, and we're figuring out ideally where their seizures are coming from. Part of that procedure is the cortical stims. So people have heard about that as a procedure that we do where we stimulate the brain to achieve certain goals. So that cortical stims is part of the procedure, usually done towards the end of the evaluation, and it's usually done over about 2 days. And what we do with this is we have two goals. One goal is to stimulate brain tissue to get the patient's habitual seizures. Because if I can stimulate, say in the right temporal area with electricity, give some cortical stimulation, so each of those electrodes that are deep in the brain, if we stimulate that and produce the patient's typical seizure, then we know that we're likely in the right spot for where their typical seizures are coming from. So that's one goal. The second goal is to do mapping. So while we're doing the stimulation for about 5 seconds of stimulation, we have the patient tap their fingers or name items, and if that function gets disrupted, we know that's a critical area for functional cortex. So those are the two goals of cortical stims: to stimulate the patient's typical seizure, as well as to actually map eloquent cortex. So these electrodes, they kind of go both ways. So these electrodes, they not only pick up where seizures are coming from when the patient has their seizure, you can also deliver electricity through these electrodes. The cortical stims team includes epileptologists, neuropsychologists, nursing staff, and EEG staff. So that's who's in the room with the patient when we're having the patient undergo the cortical stims. And really, this is really important part of the teamwork where the nurse and epileptologist will meet before the stimulation procedure. And what will happen is you'll plan safety and treatment if the patient has seizures. Remember, this is critical. We are stimulating these electrodes to purposely trigger seizures. And so you not only think that seizures might happen, you actually hope you're going to trigger the patient's usual seizure. So you have to have a very clear plan with the nurse and the epileptologist as to, okay, patient's going into a bilateral tonic-clonic seizure. What do we do? Nursing staff does this. You have the rescue meds all available. You don't want to be calling pharmacy to have them send it up. You want these medications either at the bedside or very close to the bedside when we're doing the procedure. That way the patient can be given the rescue medication, the lorazepam, diazepam. Maybe you'll want to have some IV fosphenytoin or IV Keppra close by. So the stimulation procedure, so one of the goals, as I say, is to actually stimulate the patient's typical seizure. So what you'll do is each of these electrodes, you're going to stimulate with electricity to try to get this. So let's say you're stimulating this electrode here, and suddenly you start seeing this seizure. You can see that kind of rhythmic activity and seeing how it spreads. And you would hope you would just produce the patient's usual seizure. Maybe that would be an episode of staring, lip smacking, picking at their clothes, that kind of a typical seizure. And if you can get their typical seizure, you can actually define it very nicely that you can see where it starts, what the spread pattern is, and really study exactly what brain structures are involved with the seizure. And that allows you to figure out what the most critical part of the network is for generating seizures. So you can imagine if you can, let's say in this electrode, this big green one here, that when you stimulate that electrode, that's where you get the seizures, most likely. Meanwhile, you're stimulating all these other ones. You're not getting any of those to produce seizures. Then you know that the hot spot or the most likely area where seizures are coming from are there, and you put that into the context of when you got their seizures without stimulation, that information, and then put it into context when you actually stimulate the seizure. And again, this allows you to say, okay, seizures are coming from this area, and that's going to be the best area for removing brain tissue to get rid of the seizures. So now we just covered the part about stimulating for seizures. Now, in addition, part of what we do when we're doing our stimulation studies is to see what important function is at those electrodes. Because if we're going to do surgery, obviously we want to have the surgeon go in, remove brain tissue, and get rid of the seizure focus, but not have a deficit. You don't want to have a language deficit. You don't want to have a motor deficit, and you just want the patient to have a very safe outcome. So you want to know what is the function of that area of the brain. So what we do while the patient is being stimulated, so the patient has the electrical stimulation going for about 2 to 5 seconds. And during that time, the patient is undergoing tasks. So we may have the patient tap their fingers and count 1, 2, 3, 4, 5. Or we may have them naming items. They may be shown a picture of an apple or some other object, and they need to name that. And if during the stimulation, they're not able to carry out that function, so can't name, can't count, can't tap their fingers, they suddenly stop, they're tapping and then suddenly they stop. If those are disrupted, then we know that that area is critical for function, and that if the surgeon removes that area, the patient's going to be at risk for a deficit. So what we do is we basically just go through each of the electrodes. So you go through each electrode, stimulating it, and some of those patient has no problems. They're tapping, they're counting, they're speaking, there's no disruption, and we say there's no function there. And then for some of the electrodes, there'd be critical functions, and that just allows us to come up with a map of where surgery would be relatively safe and where there would be concerns. So we obviously have a very clear kind of, at electrode whatever naming impairment, and we make that very, very clear. So the stim procedure itself, so each electrode is stimulated. So usually you start at 0.5 milliamps and you do 2 to 5 seconds of stimulation, and you do your testing for function. You see if you can trigger seizures. So they're done at the same time, by the way. So for each stimulation, you're testing with the finger tapping and the naming and all that, but you're also seeing if you're going to have seizures as well. So they're done simultaneously. And what you do is you just do one electrode at a time, and you don't start at the full milliamp. So usually we're stimulating at the very lowest stimulation at 0.5 milliamps, and then we just kind of keep going up until we get up to about 5 milliamps. And then once you get up to 5 milliamps, if there's no function, then we consider that a cleared electrode, and then we can move on. But this is why this takes quite a bit of time. This usually takes about 2 days, several hours each day. And the reason for that is because you just do each electrode and you do it very carefully, and you gradually go up on the milliamps until you can either clear the electrode or until you find function. And so that's kind of how the procedure goes. I kind of talk about this being variable, the duration of how long cortical stims will take, very much tailored to the patient's needs and also to how they tolerate it. It's a long procedure, tedious for everybody, but especially that patient in the bed who's going through it. So this is the end of the video here. And if you have any questions or any feedback for us, just let us know. Thank you.